Today we're going to be talking about Notch, Wnt, and NF-kappaB signaling. As a reminder, all these images are the property of Taylor and Francis, and the reference text is Molecular Biology of the Cell, 6th edition. This is for educational purposes only. Monetization of any of these lectures or reuse of any of these images is a violation of copyright law. I don't represent any medical facility or institution in these lectures, regardless of my place of employment at the time. So what I want you to understand about delta signaling and notch signaling is that delta is expressed on neural cells, okay? And when delta binds to this receptor called notch, it causes a cleavage of notch, all right? And the downstream effect of that is that the cells around the developing neural cell know not to become neural cells. That's important, all right? So in terms of neural embryology, neural cells will express delta. When neural cells express delta, it forces everything around them to become epithelial. Okay, how does it do that? Because delta binds notch on the cell that's meant to become epithelial and cleaves it. All right, and as we can see here, notch will get cleaved. I don't need you to worry about any of this. All I want you to understand is that notch gets cleaved over here, and the tail is going to migrate to the nucleus and transcribe genes. All right? I don't want you to memorize any of this. All I want you to know, notch gets cleaved, the tail goes down into the nucleus where it acts as a transcription factor. Now what I do want you to know is that this cleavage right here is catalyzed by gamma, pardon my not too great looking gamma secretase, all right? And that's important. The reason why gamma secretase is important is because one of its components is called presenilin, all right? Presenilin. And presenilin, you can kind of guess from the name, it has the word senile in it, and pre. So pre-senile. So let's think about that for a moment. What might this gene do? It might be associated with a form of presenile dementia. In fact, a gain of function in presenilin leads to presenile dementia. All right, so increased function will lead to dementia. And this dementia is called early onset. So it's a form of Alzheimer's, and it's an early onset familial Alzheimer's. All right, this is important. You must know this, that a component of the gamma secretase that, it cleaves the tail of notch and has a bunch of other functions. One of its components is presenilin, and presenilin, when it is mutated in families, it causes a familial early onset Alzheimer's disease syndrome. And it can also contribute to plaque formation in normal Alzheimer's disease. All right, that's important. You have to know it. Over here we have Wnt signaling, and what I want to draw your attention to is that normally, so we don't see any Wnt signal, right? No Wnt signal. In the absence of a Wnt signal, beta-catenin is phosphorylated, beta-catenin, I don't know how it's actually pronounced, is phosphorylated and bound to APC in association with axin. You don't really need to memorize axin. What I want you to know is APC. All right, that APC is going to bind, going to be part of this complex that binds and phosphorylates beta-catenin, which causes it to be ubiquitinated and then broken down. Because remember, ubiquitination is like the cell's form of saying this is garbage. So when this is phosphorylated, it gets ubiquitinated and broken down. All right, that way it cannot go to the nucleus. It cannot knock off this co-repressor called grouchy grouch. It can't knock off Groucho, and it can't do its function. In the presence of this signal, beta-catenin will go to the nucleus and it will displace this co-repressor, and transcription will occur. All right, but what I want to draw attention to, in the absence of Wnt, APC and the whole complex is bound to beta-catenin. If we go over here, what happens when Wnt binds? Well, when Wnt binds, frizzled recruits disheveled. Disheveled, there's a phosphorylation process and the recruitment of axin. I don't want you to know that. All I want you to know is that when Wnt binds frizzled, Frizzled recruits disheveled, and that causes APC to no longer be associated with beta-catenin. All right? And then beta-catenin is now stable. It's not being phosphorylated, and it can go and act as a transcription activator by knocking off this co-repressor, Groucho. All right? I don't even want you to know about Groucho. All I want you to understand, one last time, in the absence of the Wnt signal, the end result is that APC and the rest of the complex can bind beta-catenin, and beta-catenin cannot go to the nucleus. In the presence of the signaling, APC does not sequester beta-catenin. Now, what does APC stand for? This is actually extremely high yield. I promise you, you will see this in some way, shape, or form. APC stands for adenomatous. So adenoma, meaning a benign growth of an adenoma or glandular epithelium. Adenomatous, okay, epithelial, glandular, benign growth. That's what adenoma means. So adenomatous polyposis, polyp meaning a polyp, like the kinds you get in the GI tract. Osis meaning a process of developing. Coli in the colon. All right? So APC stands for adenomatous polyposis coli. Mutations in APC, so let's think about it. If you knock out APC, what's going to happen? Beta-catenin will always be transcribing the Wnt target genes in the nucleus, right? Because normally APC keeps this sequestered. When it's sequestered, it's ubiquitinated and broken down. Let's say you have a loss of function in APC, which occurs in FAP syndrome, all right? Which stands for Familial Adenomatous Polyposis, okay? In the FAP syndrome, the familial adenomatous polyposis syndrome, the adenomatous polyposis coli gene is mutated, and you do not get production of APC. Because you don't have APC, you do have beta-catenin, and that leads to transcription of Wnt target genes, which are growth genes. All right? And that's what leads to this polyposis, this process of developing polyps. So what you'll find is that at a very young age, in their late teens, people who have adenomatous polyposis coli, and it's an autosomal dominant condition. All right, this is an autosomal dominant condition. So if you have one knockout of APC, you will have the condition. And an adenomatous polyposis coli, all right, the colon will be filled with hundreds and hundreds of polyps by the age of 20. And this requires surgical removal. So you can have a total colectomy. There's a lot I'm not going to get into the surgical management of familial adenomatous polyposis, but what I can tell you from a step and shelf exam and from just a basic medical literacy perspective, you need to understand that mutations in adenomatous polyposis coli prevents the sequestering of beta-catenin, and that will lead to hundreds of polyps, a polyposis. All right, I'm emphasizing this so much because you will be tested on it at some point, or it will be in a clinical vignette, and you'll just need to know it. I had a patient who came in his mid-60s. He doesn't know he has FAP. He doesn't know that. Okay, he got his procedure done, maybe had a total colectomy done back in like the 70s. All right. But I had to understand that all of these polyps, he said he had hundreds of polyps, they removed his entire colon. And where does my mind need to go? Okay, he might have had adenomatous polyposis coli. And the next step was, all right, well, if he has this and he came in for a GI bleed, so that was why he was in the hospital. He had GI bleeding and anemia. So I had to say, all right, where is he losing the blood from? If he has FAP, odds are the next most common tumor besides the colon tumors, because he had a whole colectomy, would be in the stomach and the duodenum. And that's what ended up happening. He did have masses in his stomach that were causing a bleed. All right, so this is a very important high yield topic. And just to linger a bit more, I'm just going to introduce the concept of something while we're talking about, GI bleeds, etc. So when a patient has anemia, when a male patient has anemia, specifically iron deficient anemia, which is what this patient had, it's going to be GI bleed until proven otherwise. All right? An iron deficiency anemia in a male patient is a GI bleed until proven otherwise. In women, you have to think of gynecological disorders as well and GI bleeding. So with women, you have to think of both. With men, you need to think of GI bleeding. All right? This is very important. So just to do a super fast pass summary of everything we just said. In normal patients, this system is intact. You do not have transcription of Wnt target genes, in the inappropriate context. You don't get the FAP syndrome. In patients with a mutated APC, normally Wnt has to be here for beta-catenin to do its signaling. In patients with mutated APC, none of this has to happen. So this is the constant default, which leads to a lot of growth, particularly in the colon, and you get a polyposis. This polyposis will present in the teen years and requires a total removal of all the polyps, sometimes a colectomy. And if there's bleeding from a polyp, it'll present as anemia. So the first presentation, whether it's an FAP or something else, the first presentation of a gastric malignancy or growth can be shortness of breath from anemia. All right, so iron deficiency anemia is a GI bleed till proven otherwise. And then there's some other common stuff like alpha thalassemia, but that's not really the scope of this talk. All right, very important slide. All I want you to really understand here on this slide is that TNF-alpha binds the TNF-alpha receptor. You don't need to know any of this really. All you need to know is once it binds to the receptor, that allows NF-kappaB to move into the nucleus and transcribe its target genes. All right, and these are inflammation-related genes, and that's important, and you do have to know that. TNF-alpha binds to its receptor. The downstream effect of that is that NF-kappaB is free to move into the nucleus and transcribe target genes. Now, let's say we wanted to have a very targeted molecular biologic therapy. So let's say we're putting our patients on, anti-inflammatory steroids, etc. And it's like, what, the side effect profile isn't working for my patient. They've got osteoporosis. They're getting, adrenal insufficiency. This isn't working. We can't do this long term. The patient isn't tolerating it. They're getting ulcers in their stomach, etc. And you're like, okay, how can I target the inflammation very specifically? There's some conditions where what we use is a monoclonal antibody. If you remember, an antibody binds an antigen and that recruits the immune system, but they can also have a therapeutic use. What we do is we design an antibody that will bind the receptor. So instead of TNF-alpha binding its receptor, the antibody binds the receptor and no response happens. That way, we can block out all of this just by binding with this one antibody on this receptor. And that's a very targeted form of therapy. All right? That's all I really want you to know. Best of luck, and I'll see you next time.